Well, we'll get started. Good morning. I am Tom Harlow, Program Director with Rural Health Redesign Center, and we oversee the Northern Border Region Technical Assistance Center. And I'm joined this morning by my colleague, Josh Miller, Program Manager for the Northern Border Region Technical Assistance Center, and Janice Walters, Chief Operating Officer of Rural Health Redesign. You can find additional information regarding our organization and our program on our website, which is HRSA.gov. Just a real quick housekeeping. We do ask that you submit any questions you may have in the designated Q&A section in Zoom, and we will make every effort to address them during the session. In the event that we're unable to answer all of the questions during the allotted time, just be assured we will address any outstanding questions when we release the session recordings. We appreciate your understanding and your active participation. So welcome to our first of 4 webinars focused on value-based care. Today, we have the immense pleasure of introducing a distinguished expert in the field of rural healthcare, Dr. Clinton McKinney. With a career spanning nearly 4 decades, Dr. McKinney brings a wealth of experience and insight into addressing the unique challenges and opportunities in rural healthcare settings. Dr. McKinney began his career as a rural family physician, dedicating 14 years to practicing the full scope of family medicine. He is actively engaged in efforts to improve rural healthcare systems. As a national rural healthcare consultant for 8 years, he has collaborated with approximately 75 rural communities to enhance their healthcare organization performance. Dr. McKinney is a prolific contributor to the field with his publications and national presentations focused on themes such as healthcare value, physician and administration relationships, rural hospital payment, and rural health policy. So please join me in extending a warm welcome to Dr. Clinton McKinney as he shares his invaluable knowledge and experiences with us today. So Clint, take it away. Pleasure to have you.
Well, thank you very much, Tom, and good morning to everyone who is on the call. And thanks very much for joining Tom, Josh, and Janice and me on a little bit of time. We're talking about value-based care. Now, I do want to tell you where I'm coming from. I am part of the Rural Health Value team, and we are a team composed of folks from the University of Iowa, where I work, and Stratus Health, the quality improvement organization based in Minnesota. And we're funded by the Federal Office of Rural Health Policy, along with other organizations, to do this kind of work, actually promoting and advancing rural health value. So you can see on the slide, we develop tools, we interpret health policy, we try to disseminate best practices, we even do direct technical assistance, and we share experiences around this journey from volume to value. Now, one of the ways I think about value is I think about what would a conversation be like if you were to sit down with a close friend or a family member, share a beer or share a glass of wine, and maybe ask that family member in maybe not so stark terms, when you go see the doctor, you go to the hospital, what do you expect? And here's what I think with some thought, most of our friends and family would say. Well, geez, I want to be made better. If I'm ill, I want to be well. Oh, and by the way, I prefer not to get ill at all. So I want to have good preventive health. Oh, and another thing, when I go to the doctor, I want them to understand that I am maybe frightened or confused or in pain. And I want to be treated with compassion and respect and sensitivity to my own perspectives. Oh, and one last thing, I pay a lot of money in health insurance premiums, or I pay a lot of money in taxes, and a lot of that goes to healthcare. And I want you to use my hard-earned dollars wisely. Now, you notice that our friend or our family member didn't say, I want to be seen by my doctor as fast as he or she can do so, or I want to be placed in the hospital, but then moved out of the hospital as fast as possible to make room for another patient. Nobody said that. Instead, they talked about getting good quality. They talked about improving the care of just not myself, but my family members. They talked about using my resources wisely. They talked about treating me respectfully. So what am I talking about with this? What is this? Well, this is the triple aim. And you've probably heard of that but I want to kind of bring it home to the fact that this is what most of us want when we access the healthcare system. So I'm going to argue over the next 45 minutes or so that shouldn't we be getting paid, we as healthcare providers, doctors, nurses, hospitals, physician assistants, nurse practitioners, shouldn't we be paid for what our patients and our communities want and deserve? I add here also the quadruple aim, which is professional fulfillment as well too. So what our society, our families, and our friends wants is we want better care, high quality and respectful care. We want improved health for our friends, families, and our communities. And we want this healthcare system that's so expensive to start using our money wisely, smarter spending. Now this triple aim translates to the value equation. I got to take you back. So in 2006, I was asked to give a talk up in the Upper Peninsula of Michigan. And my subject was, in essence, tell us why the government and insurance payers are messing with healthcare. And I kind of came up with the idea in 2006 that I think it's because we're not giving the value in healthcare that we know we're all capable of. We know we can provide better quality. We know we can provide a better experience. And we know we can probably do it less expensively. Then in 2008, Don Berwick came along and wrote an article talking about the triple aim. I didn't know the word triple aim back in 2006. But as Janice and I have talked about, it was very affirming to hear that. So I've really found a place with the triple aim. I think it speaks to what most rational people want from the healthcare system. It speaks to what I think we should have with the healthcare system as well too. So what do we have now, and what do we need to start moving towards? Well, today, fee-for-service predominates. Now, what fee-for-service means payment to a healthcare provider, doctor, hospital, clinic, pays for each unit of service, each office visit, each CBC, each CAT scan. We get a fee for each one of those services. It's not all bad. It rewards industriousness. It makes people work hard, and it can reward efficiency as well too. But I'm arguing it contributes to the high cost of healthcare in the United States. I also am going to argue, like this graphic of the doctor on the hamster wheel, it worsens professional satisfaction. So what's an alternative? The future, value-based care. And this requires something different than what we primarily do right now. It requires team-based care, It financially rewards better care and efficiency. It tends to increase quality, and the data are just starting to show that it reduces healthcare costs. That's been a little bit slower to come about, but I think it's coming. And in the best situations, it absolutely does improve professional satisfaction. So let me kind of define this word for you, value-based care, okay? Value-based care prioritizes high quality, person-centered, and efficient care, but it does not prioritize the volume of services provided. That's fee-for-service. Again, in fee-for-service, the more you do to somebody, the more you get paid, whether it helps, hurts, or does nothing for that patient. So value-based care does not prioritize volume of services provided. It requires what I call robust primary care as an essential ingredient in this value-based care equation. As in, you may have heard them as patient-centered medical homes. We prefer to use a little bit different language, person-centered health homes. And as you can see in my graphic, it emphasizes person and family. It's focused on quality. It's proactive. It's not waiting for the patient to come to us to say, isn't it my time to get my mammogram? It's proactive and reaches out to that woman to get her mammogram. Heck, my dentist and my veterinarian do a better job than many medical clinics do about proactive care. And it's team-based as well too, with all members of our team operating at the top of their license, experience, and comfort. Team-based care. But we have a problem. So some of you may know who this character is in the graphic. And I'm not sure he actually said this, but nonetheless, it would be perfect if he did. You can always count on Americans to do the right thing after they've tried everything else. So in healthcare world, what have we tried? Well, we tried fee-for-service. And that's why I told you again, just as a moment ago, this is payment for individual services, whether it helps, hurts, or does nothing for the patient, fee for service. Well, then there's full capitation. Now, we've had some experiments with that as well, too. Now, capitation pays you the same amount no matter how much you do for the patient, whether that doing or not doing does nothing for the patient or does everything for the patient. Well, I'm not sure that makes much sense either. Those of us in rural America understand that a market-based approach, which is volume-based approach, doesn't always work when we have sparse populations and low service volumes. A lot of people will ask me about single payer. Single payer probably adds some efficiency, but it doesn't still get at this value idea that I've been discussing. So what about paying for healthcare value? Oh, how novel would that be? Now, the reason why this is important is this simple truism: form follows finance. Form follows finance. How we deliver care depends on how we are paid for care. Now, admittedly, it's not exclusively that, admittedly. But if you're paid in a certain way and you've been paid that way for maybe decades, it's very hard to think or envision a different way that might be better. But healthcare reform is starting to change both the way things are paid, and I would say then consequently, the way care is delivered. It's this payment that supplies the fuel, the push for the volume to value transition. So now I just described a few slides ago, value-based care. So let me pause now and describe value-based payment. So this is payment for one or more parts of the triple aim: better patient care, quality and patient experience when we talk about better patient care, improved community health, talk about that, so the whole community is becoming more healthy and vitaler, and then smarter spending. It's not payment for an individual service. It's not payment for that individual CAT scan or CBC. It's not fee for service. But here's the kicker. If we kind of like this idea of getting paid and we want to get paid with a value-based payment, we've got to be able to deliver the value-based care that I was describing earlier. Now, you may pause for a second and say, geez, now wait a minute. This Clint McKinney is a rural family doc, as Tom introduced to me. And that was my whole career. It was. When I started in practice in 1985, I had 25 patients on my schedule, and it never got less. I don't really think I had the wherewithal, let alone the time, to be able to kind of wonder, is there a better way to do this? I was in I got paid per office visit, or I got paid per hospital visit or nursing home visit. That's the way I paid for my kids' college or paid my mortgage. But I began to understand in this payment realm that money really is the medium of exchange. It's how we kind of think about how things get valued in what we do day to day. It's the economics of everything. And I also kind of became a fan of behavioral economics. And behavioral economics is all about incentives. And incentives drive behaviors. Now, of course, you all know, and I want you to know that I know, that not all incentives are financial. Of course, we have professional and personal incentives as well, too. Of course we do. But finance still nonetheless remains important. So if it is, let's incentivize the triple aim. Let's pay for better care, improved community health, and smarter spending. Let's make it easy to do the right thing that, as I said in the very introduction of this presentation, what probably, if we sit down and talk with our family and close friends, that they expect from us. Let's make it easy to do the right thing. So that's why I'm discussing payment. Now, you can think of payment on a continuum. From all the way to the left side of your screen, volume-based payments, all the way to the right of value-based payment. It's not like a light switch of off and on volume value. It's a continuum along this path from the left to the right. Over on the left, we have volume-based payment, which is fee for service. And then along the way, we have pay for performance, value-based purchasing, shared savings, bundled payment, global budget capitation and capitation. We'll talk about a couple of those a little bit later. And then at the far end, total cost of care, which is through completely value-based care. That total to the right is very, very rare. All the way to the left is very common. And then we have this kind of mixture in between that we'll talk a little bit more about in a second. So here's some examples of value-based payment examples. Again, we're going to talk about a couple of these: shared savings and shared losses. An example of this is the Medicare Shared Savings Program, or ACOs. Global hospital budget, which is the Pennsylvania Rural Health Model, which Janice will tell you about in a later webinar. Partial capitation. Look, if you're not familiar with it, look at the Primary Care First model, a Center for Medicare and Medicaid Innovation model that provides partial capitation to primary care. And then total cost of care. I told you it was very, very rare, but again, for an example that's approaching that, the Maryland total cost of care model is worth looking into. So these are examples that are going on right this moment. So if we think that this value-based payment isn't a real thing, think again. It is. It's going on right now. Now, here's by the numbers a little bit. So I mentioned that it's going on right now. Accountable care organizations. There's 938 of this beast. 10% of the population are enrolled in an accountable care organization. Just in Medicare, 438 Medicare accountable care organizations with about 11 million people in them. This is a lot. And then there's other models. Now, models are like demonstrations or they're tests. Multiple, I mentioned the Center for Medicare and Medicaid Innovation. Multiple models going on, like rural hospital global budgets, that is in Pennsylvania, and primary care and partial capitation, primary care first. And then beyond Medicare, which we know the most about because it's national, we have a lot of Medicaid and commercial insurance value-based plans. Blue Cross Blue Shield, I think I read recently, has like value-based payment plans in 48 of the states. One of them is called Blue Alliance. And here's something really important. At the last part, the end of last year, early winter, I believe, CMS said this, that all Medicare beneficiaries and almost all Medicaid beneficiaries should be in an accountable relationship with a provider who's accountable for cost and quality by 2030. Now, it's not like Medicare rules the world, but nonetheless, how Medicare goes, so goes other places and other payers. So we should be paying attention to this. 2030 is not that far off. So if we think that value-based care and value-based payment is going away, again, please think again. It is not going away. It's going to get more and more prevalent. In fact, I'm working with the Blue Cross Blue Shield in one state right now that told me that they are going to have no inflationary increases in their rates paid to hospitals and doctors this coming year. All of the inflationary increases are going to be going into value-based payment type plans. So again, if you are in this particular state and you are expecting an inflation increase to make up for all the cost increases you've had, workforce, IT, all those 10, 12% cost increases, and you're expecting to see that increase in your payment from Blue Cross Blue Shield in this particular state, ain't going to happen. It's going to be in value-based payments. Now, let me talk about a couple of these examples for you. I want to talk first about accountable care organizations, or ACOs. These are also known as shared savings organizations. Now, I'll explain that in just a little bit. But an ACO is a group of providers. It's generally physicians and or hospitals that come together and are incorporated together, and they sign contracts to receive financial rewards for improving quality of care for these group of patients and reducing their costs. So that's what the contract says. If you reduce costs and you achieve certain quality metrics, then we will share back with you some of the savings we as the insurer or the payer or Medicare earned on your work. So here's some of the basics of how this kind of works. Now, again, it has been modified. So this isn't exactly the way it is based on new changes to the Medicare Shared Savings Program, but it'll still give you a good idea of how ACOs work. So we take a particular beneficiary or a patient, and we calculate that this particular patient last year cost $10,000. That's how much. I'm going to use Medicare as my example here. Medicare paid $10,000 out for all Part A and Part B costs over the past year, $10,000 for everything, Part A and Part B. Then we enroll this patient in an accountable care organization. And this ACO starts to apply preventive health measures, care coordination, readmission reductions, home visits, a variety of things to start to lower the cost of care for that particular patient. And lo and behold, in this particular example, when we do the calculations at the end of the year, Medicare has only spent $9,500 on that particular patient. So that leaves us $500 that Medicare just saved. They didn't pay out $500 that they thought they were going to be paying in this last year. So what happens to that savings, that $500 savings? Does it all go back to the government? Well, not quite. So Medicare decides in this particular example to share 50% of those savings back with the ACO. They're going to cut a check for $250 at the end of the year back to that ACO. Now, hold your horses. You got to perform on a certain quality metrics. If you don't perform adequately on a quality metrics, your payment may be reduced. In this particular example, it's reduced to $200. So in this example, for this one patient, remember, it may be 5, 10, 15,000 patients, Medicare writes a check back to the accountable care organization for $200. Now you notice here, the house always wins. The house wins because Medicare just kept the $250 that you saved, or the $300 that you just saved. But nonetheless, this is the way the shared savings model works. So our goal as an ACO is to receive a share of that cost savings. Now here's what it requires. It requires care in outpatient. Those quality metrics are outpatient metrics. You have to have the patients assigned to your ACO. It's called primary care visit attribution. You need to be really good at managing the health of a population and managing financial risk. And this all requires that robust primary care that I was describing to you before. However, this is still fee for service. And I say that because all through that year, when you're trying to save money, you're still billing Medicare every time you do a CAT scan, every time you have an office visit, every time you have a hospitalization, you're billing Medicare all the time. Fee for service. Only at the end of the year is everything reconciled to see, did you actually bill Medicare less than what they predicted? And if you did, you get to share in those savings. And unless you think this is only an urban thing, it's not really. You can see in this chart, which talks about percent of accountable care organization lives in the state, where there's some rural states that this is quite active in. So significant rural participation in this. Let me talk next about global budgets, and Janice is going to talk more about this. So I will talk about it in all the most basic of ways. But this is for a global hospital budget is what we're talking about in this case. In a global budget for the hospital, a hospital may look at its trend of revenue over the past few years. And if we see a trend like I'm kind of depicting here in the red, it doesn't look very good. Now, maybe that trend is going on because of patients' loss or care is moving out of the community. For whatever reason, we're seeing our revenue going down in this particular sample hospital. And we think if this trend continues, the dotted red line, this doesn't look very good for the finances of my organization, especially when most costs are going up. So if we were to be offered a global budget, the global budget, let's just say it happens to be set based on, in this particular example, my 2019 revenue, that global budget is maintained. That revenue is maintained through the years, even though the trend line was going down. So you can kind of see the difference between these two lines here. We can see now we've got revenue that's stabilized, and we have our trend line, which is going down. So we're doing much better off than we predicted. This came very true in COVID. It was kind of an absolutely unplanned and natural experiment when obvious hospitalizations dropped to the bottom early in the pandemic. So there's no revenue coming in. Now, admittedly, COVID relief funds helped kind of make up some of that difference. And then as people became sicker, then obviously some of that volume came back. But you get the point. The point is, if our trend is going down and we need a way to stabilize our revenue in that trend, global budgets are one way to do that. Now, Janice is going to talk a lot more about this in the future, but I want to talk about here just a little bit of the potential of the global budgets beyond finance. So wouldn't it be kind of interesting if you're a hospital leader, wouldn't it be interesting to start thinking about how can I help my staff, my clinicians and other staff think about what's best for our patients, not what's best for putting revenue in our coffers. Wouldn't that be interesting? Wouldn't it be interesting to have this opportunity for innovation where I was unshackled from waiting for a fee for service every time? Wouldn't it be fun to not look forward financially to a flu epidemic where I had to have more people hospitalized? Wouldn't it be fun to be able to think about getting paid for improving the health of my community? And you know what? I'll bet you $10 if we look at most hospitals in the country, that's what their mission is going to be. It's not, the mission isn't going to be necessarily, wait for the next flu epidemic so we can fill our beds with flu patients. It's going to be, how do we make our patients and our communities healthier? This is the duty of a not-for-profit board and leadership. So we should be eager for this kind of opportunity. Now, admittedly, ensuring organizational success financially is also a duty, so you need to be thinking about that. And I think global budgets tend to make balancing these demands easier. The demand for financial success, but also the demand for serving our mission to improve the health of our patients and our communities. Very, very exciting opportunity. Janice will talk more about that, though. So I want to kind of talk a little bit more now about what the volume to value movement starts to portend. So please let me kind of repeat now the CMS 2030 accountability goals. They said, to paraphrase, all Medicare fee-for-service beneficiaries and most or almost all Medicaid beneficiaries will be in a relationship with providers that are accountable to quality and cost of care by 2030. Geez, that's like 6.5 years away. That's not very long. And again, they're starting to move in that direction. Now, Medicare will say that Medicare Advantage is a value-based plan or value-based system. I'm going to disagree. So for those of you who are familiar with Medicare Advantage is a Medicare plan provided through a commercial insurer, for example, Humana or United, et cetera. So, and what happens in Medicare Advantage is that the government pays each of these commercial insurers a per capita rate to provide all the care that traditional, or the better word is original Medicare would provide. And Medicare Advantage plans have really done, I think, quite well with this. And what they do is because they know that they can make money here, they offer enticements to individuals to join, like free dental care or free health club membership or reduced copays, on and on and on. But the key here is they very infrequently transfer down that value-based payment actually to the hospitals, doctors, nurse practitioners, physician assistants, et cetera. That doesn't transfer down. So even though I think Medicare is counting that as a value-based plan, I don't quite buy it. In fact, as I mentioned before, even accountable care organizations, shared savings plans are still built on a fee-for-service chassis. But nonetheless, despite my quibbles with Medicare Advantage and my quibbles with shared savings plans being truly value-based, we are going to continue to see this gradual devaluation of fee-for-service. So for those of you who are looking forward for your organization, especially those of you who are looking forward for the finances of your hospital, I ask you to start thinking about how well are you going to do as fee-for-service payments start to dwindle over time, or at least not keep up with inflation. Remember that about cost-based reimbursement. For those of you who work or are employed by critical access hospitals, critical access hospitals by Medicare and some Medicaid programs are paid cost-based reimbursement. But sequestration removed 2% from that original 101% of cost payment, now to 99%, and not all costs can be counted. So therefore, critical access hospitals make somewhat less than their cost of delivering the service in their payments. So I ask people, okay, if you're in a system in which your organization gets paid even a little bit less than what it costs to deliver that service, how much profit are you making? Well, the answer is, it's easy, less than zero, less than zero. So critical access hospitals only make up their profits in their commercial market lines. So what happens to your fee-for-service revenue when Blue Cross Blue Shield says to you, we're not going to give you any, quote, cost of living increases this year, no inflationary increases this year in our payments. If you want to get increases in payment, you're going to have to go think about value-based care to receive value-based payment. That's this gradual devaluation of fee-for-service. Moving instead towards, again, not a light switch, this is a transition towards payment for delivering better care, improved health, and smarter spending. And what am I talking about? Triple aim, of course. Now, as I think I emphasized, this requires and rewards strong primary care participation. So for those of you who are in hospitals and you either have relationships with or own primary care practices, be sure to be thinking about how you can support those practices do this kind of work. And if you don't, there are for-profit companies in this world that are happy to take over your those practices for you. And believe me, they don't do it just out of the kindness of their heart. Don Berwick, I mentioned him earlier, spoke at the Institute for Healthcare Improvement conference. I think it was in December in Orlando. And he showed a slide of the top 10 compensations for CEOs of all organizations in the United States, all of them. Guess what? 3 of the top highest paid CEOs worked for an organization that buys and manages primary care practices. Oak Street Health. These folks are making upwards of $500 million a year in compensation. So those particular organizations are going to be in your backyard, and they understand the value that primary care can bring to this value-based payment world. Now, I don't want to sound all negative because I'm excited about this. I'm excited because it's an opportunity for us to better deliver on your healthcare mission. And I suspect if we were to look at your missions and your healthcare organizations, they do at least say or allude to improve the health and the lives of the patients and the communities we serve. It says that. And here is an opportunity for you to do that in a way that doesn't cost you money. And in fact, just the opposite, is going to start to reward you as well. So that's what I think it's pretending. Crystal balls are always tough, but nonetheless, I think that's what it's starting to do. Now, how do we get there? We have all of our processes set up in our hospitals and our clinics to not only maximize, but pay attention to volumes. Why do we do that? Because that's where our payment comes from. That's where it comes from. So we set up our processes. Just think about board reports to the hospital board. What do they include? They include things like admission rates, ER volumes. Maybe they might talk about average daily census. They may talk about patient days. Those are all volume metrics. They don't have anything to do with the care an individual patient receives or a community receives. Would we ever start thinking about the number of emergency department visits that we avoided because we had good primary care? Could we start measuring that? Could we start measuring the number of readmissions that were avoided because of good home care and good follow-up after the initial admission? By the way, they are starting to measure that now because in the larger hospitals, there's a penalty for high readmissions. So they are starting to think about that now. But wouldn't that be an interesting kind of difference to think about at a board meeting, to think about how are we serving our mission rather than how are we increasing our volume-based revenue? Now, this doesn't just happen kind of all by accident. And I kind of said we kind of need training wheels here. So what we need is discriminating approaches. We need to understand what's going on in the environment, what's going on around us. That's actually part of the purpose of this talk, to help you understand a little bit better how this volume to value transformation is coming, albeit more slowly than I really want, but it's still coming, and how we need to start getting prepared for it. It requires sophisticated projections. This is not easy. This is not the typical GAAP accounting method, generally accepted accounting principles. It doesn't quite work as well as when we think about revenue and expenses, income and costs on an income statement. It just doesn't work quite as well. It requires some experimenting. Now, I got to admit, there's some pretty cool experiment options open to people through the Center for Medicare Medicaid Innovation. These are models, they call them models. That's kind of an experiment where we can participate in value-based payment plans in a relatively low risk way. There's actually brand new regulations that were just released for the Medicare Shared Savings Program that allows folks or organizations who haven't been an ACO before or have limited experience with an ACO to get into that program with some upfront cash funding and per member per month payments, or actually interest-free loans. But if you just can't go, if you stick with the program, I think for 4 years, if you stick with it and you can't pay back these interest-free loans, the loans are forgiven. So it's a relatively low risk way to get into the volume to value world. And then we need to make sure that our organization is continuously learning. Now, that's not a new concept. We need to do that all the time. And again, by participating in these webinar series, you are learning continuously. And I ask you to bring some of these insights back to your organizations. This is being recorded, so you can sure share it. And then reminder to, especially for healthcare leaders, that this is really all about balance. Right now, 2023, we have to optimize our operations so we can remain fiscally viable. Everybody understands that. And that's one of the joys of working with Janice and her team. We understand that the key focus here has to be that we optimize our operations so we can be a going concern, so we can be successful financially in the future. But that doesn't mean we put our heads in the sand. We can still test new ideas, and we should be doing so, again, like the Pennsylvania Rural Health Model is doing with Janice and her team. So I do have a to-do list for you as we start to wrap up here and start to take some questions. You know, we don't think in healthcare too much about the concept of research and development, R&D, but we really should be. We should be doing R&D just like every other organization does. And we should think about what % of our profit can we invest in R&D. And I would argue that value-based care is one of the best places to invest your research and development. I'm going to preview a little bit something that my colleague Carla Wang is going to talk about later on in this, actually, I believe the fourth episode of this webinar series will be the value-based care assessment tool. This is a tool that's available online for free that helps you understand better where your opportunities to develop value-based care capacity in your organization exist. Think about financial risk thoughtfully here. Remember that the future currency is going to be less so the number of CT scans, the number of CBCs, the number of office visits, the number of admissions you do. It's instead going to be enrolled patient lives. Do you think that those for-profit organizations that are scooping up primary care practices are interested in the money that increasing primary care office visits can provide that organization? No way. No way. They are interested in the largesse that can come from doing primary care right. And they want a piece of that largesse. That's what they're there for. Enrolled patient lives is going to be the new currency for healthcare in the future. And lastly, I would ask you to keep your North Star. As we think about all of this, if you think about improving the care for patients, improving their experience in a time when they are frightened, confused, or in pain, that's a North Star. If you can remember that we, especially we in rural, live in the community of others, and that we have a responsibility for the health and vitality in the community in which we live. And we also have responsibility to use hard-earned dollars, whether they be health insurance dollars or tax dollars, wisely and without duplication, without unnecessary costs. And then lastly, this is the quadrupling. Please keep in mind the professionals that work for you. And this isn't just clinical professionals. This is administrative professionals as well, leadership professionals. This is tough work. This balancing is tough work. These transitions are tough work. And then we layer on that the mother of all challenges, the pandemic, and how stressed that was in some of the most amazing people in the country who are serving all Americans. Think about how we can make their lives fulfilling as well too. Now, I'll end up with this. I don't know if you all are Apple folks or PC folks, but most of us agree that Bill Gates is a pretty smart fella. And he said this: we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. We need to be in this for the 10. We need to be in this for 2030, like CMS is. So we need to start making those transitions, not the light switch, transitions now. So I encourage you to start thinking about value-based care and value-based payment in your organizations. And here are some folks that can help you do it. Now, you all have the slides. You can't just read it all at once, but there's lots of folks out there who are interested in this just as I am, and just as Janice is, and just as Tom and Josh are. We all are, and we're all here to help you make this transition. So lean on us. We're here to be helpful. And here's the goal at the end. We want communities and critical access hospitals and rural health clinics and FQHCs. We want them to be healthy and vital. We want places for our kids to be well educated and to grow up being happy and playful. We want to have places and communities where our workers are productive. And of course, we want communities in which our elderly feel safe and secure. Thank you all very much for listening to me. And I will turn it back to Tom, and we can take some questions.
Great. Clint, thank you very much. Great overview. And again, I would remind folks, if you have a question for Clint, just put it in the Q&A. And if we don't get to it, we certainly will respond. Clint, really a great question from Donald. And again, I'll paraphrase, but he talks about, fee for service does raise costs in theory, but then talked about a little bit, referenced utilization, but that utilization in the US is really not any higher than other wealthy economies. So his question is, the difference appears to be cost, not utilization. Why do services cost so much?
Boy, is that a great question. I'm not an economist, but I'm going to quote probably one of the most brilliant healthcare economists, who unfortunately has recently died, Uwe Reinhardt. Uwe Reinhardt said, "It's the price is stupid." And in fee for service, the classic economic equation is price times volume equals revenue, or something close to that. Again, I'm not an economist, but it's price times revenue, price times volume equals revenue. So you're right. I think that volumes in the United States are not out of skew from other countries when you look at volumes globally. But I would say I'm not sure that we're in procedures and certain testing that we're not over utilizing in the United States. We're underutilizing probably in primary care visits, or at least primary care interactions. I do think that there's a tyranny around the office visit, but I think in primary care interactions, we're probably underutilizing. I would probably say in hospitalizations, we're probably on par, if not a little bit less than the rest of the country. So I'm not sure that's really the issue, but prices are. And the variation in prices across the country, for example, for procedures and for hospitalizations is frankly just embarrassing. It really is. So I think if we start to get at understanding price variation better, understanding what the right volume is, and understanding that volumes are not necessarily comparable, that there's nuances in the volumes, I think we'll get a better handle on your very excellent question.
Great. Thanks, Clint. Donald, great question. And just as reference, we did have someone anonymously post, Don Berwick did publish an article in JAMA after that event appears. So it is referenced out there in JAMA, and it just came out. So thank you for posting that.
Yep, it did. It did. Yes, just did. So take a look at that JAMA article. If you can also get the video on I don't know if YouTube did it or not, doesn't matter, but it's available on the net. His speeches are always just drop dead amazing. And this was no different. And actually what he alludes to in the article and in his speech is greed in the US healthcare system. So yes, Berwick is almost always worth a read. Thank you very much for reminding me that was just in JAMA.
Yeah. And I'm going to jump ahead. Clint, the next question is, do you have any examples of how this, and I believe value-based care, is being applied to EMS and ambulance services?
Oh, thank you. Not value per se, because really, and I actually, in my other work, I've just written 2 policy papers on EMS, one from federal perspective, another from state policy perspective. So that's on the the RUPRI Rural Policy Research Institute website, those 2 EMS papers. So thank you very much for the question. There's not as much value-based care work going on in EMS, but I'm gonna list a couple of examples how we're maybe getting at it a little bit. So some of you may be familiar with community paramedicine. Actually, a good buddy of mine really got that started in the United States, Gary Wingrove. And in any event, community paramedicine takes paramedics and kind of almost puts them in a public health role. And if a community paramedic is able to reduce, for example, readmissions to hospitals, and that particular hospital is involved in a global budget, as in the Pennsylvania Rural Health Model, that is indeed a value-based care intervention. And also there's opportunity to improve quality as well too. So that's kind of one example. The other example that really isn't written as much about value is the emergency triage and transport. I'm missing something. ET3 CMMI model, which actually pays for ambulances to go out to, say, a home and transport that patient either to a clinic or to some other lower acuity level other than emergency department, or not transport the patient at all, kind of treat on the scene and then depart. So again, the idea is that if we can reduce ED visits through the ET3 model, and forgive me for missing one of the T's in there, that also would be a value-based intervention because we're reducing ED emergency department costs.
Clint, we have about 10 minutes left, so a lot of good questions. Cheryl asked a question. I'm really anxious to hear your answer on this. And her question is, how does one measure health improvement? Great question.
Oh, man. Okay. So right now, and it's funny that you should ask that, Cheryl, because this is a conversation we've just had prior to this webinar. So right now, I'm gonna shift your question just a little bit. Is how do we measure quality? I'm gonna start off there first. And there is a lot of debate about how we measure quality and whether we're measuring quality in the right way. So ideally, we want quality to be measured with clinical outcomes in an ideal world, but we all know that clinical outcomes can be a decade off. So if we have good hemoglobin A1C control, we may not see a drop in amputations for 10 years. And geez, for whatever reason, our government and our payers just cannot get their heads around changes that occur over a decade as opposed to occur over a year, let alone a quarter, but so they're having real trouble with that. So instead, we rely on process measures like hemoglobin A1C and mammography rates and colon screening rates and chronic disease management processes, almost in hopes that they translate to good outcomes, clinical outcomes later on. But some of our debate was what is health? And some would argue that health is in the eye of the beholder. So have we spent as much time asking our patients what they expect from the healthcare system? What do they think health looks like, for example? How do we mix together longevity and quality of life? How do we take into consideration the elderly woman who prefers to stay in her local community for her cancer care, even though the cancer care in the big city 2 hours away is more sophisticated and actually maybe statistically more likely to result in a longer life for her? How do we take that into consideration? So I don't know if there's any set pat answer to your question, Cheryl. It's a really, really good one. And I would ask those on the call to be thinking about the necessity for these process measures, but understand how we get to the outcomes more readily, or to understand those connections. And then also start to think about how do we start including patients in these conversations and understanding what they want out of the healthcare system. That may be an incomplete answer, Cheryl, but you've asked a really tough one and a good one.
Yeah. Clint, thanks for trying to tackle that. I'm going to jump ahead. We have about 6 minutes left. And I just, Meredith had asked a question, and this is really in the community health center space. And her question is, if you're creating a new community health center, how soon do you think a community health center could be completely value-based?
So community health centers, I'm not an expert here, Meredith, so you're going to probably be more expert than I am. But community health centers are designed around comprehensive care. So already you've got a leg up on a lot of other practices by incorporating, for example, behavioral health services, dental services, maybe pharmacy services. You're already more team-based than a lot of places. So right there, we're starting to get at an essential part of what I think will be robust primary care, which is indeed then central to value-based care. So already you're getting there. If we start adding to that more patient-centeredness or person-centeredness, better word, person-centeredness, we are starting to think proactively. When I was in private practice, and I never got to this, what I would have really have liked is that when the team and I first huddled, the primary care team and I, if we had one, first met in the morning and huddled in the morning, we had a list of patients on our panel that we were responsible for, and we knew exactly what care they needed before we started our day. So our job was to ensure that we had a plan for ensuring that all of the patients on our panel received the care that they got. We had a plan for that at the beginning of the day. I never really got to that, but I think as technology gets better, I think we can start moving that way. And maybe the FQHC is going to be the closer way to get to that than I was able to get to. I certainly hope so. Now, the other thing is maybe, I don't know if your question is all about value-based care or value-based payment. So again, you're going to have to forgive my ignorance, but am I remembering, and again, you don't have to answer, but I think I'm remembering correctly that FQHCs were kind of moved into a PPS type payment system, a prospective payment system. If that's indeed true, it's not pure fee-for-service, but it's still fee-for-service. If it's prospective payment, the more services you provide, the more visits you provide, the more you make. So we're still not quite to value-based payment yet. So, and I guess I just don't know if I don't think they are. I don't think FQHCs are eligible to participate in the primary care first model. I don't think they are, which is really unfortunate because it's a cool model that pays primary care providers on a tripartite method of payment that includes a capitated payment. It's a population health management payment. So it's one payment per patient per month or per year. And then it also has a fee for service component. So you're incented to see people and do work. And then there's also a component around performance or quality performance. There's a tripartite. And the cool thing about that is the payers or providers together better can start adjusting those percentages as the processes get better for one or the other. And eventually what I'd like to see would be to actually start phasing out the fee for service. In fact, I was just on a webinar just a little while ago with one of the leaders at Cleveland Clinic. And under his watch at Cleveland Clinic, they moved all their primary care providers to about 75% capitation. Whoa, 75%. He said it was an absolute game changer that allowed the primary care providers to start thinking about how do we care for our panel, not just caring for individual patients in an office visit kind of mindset. So good for you for thinking about that. I think you're going to be greater potential at the FQHC than in many practices.
Great. Thanks, Clint. And I know we're running up against our time here. There were a couple questions or requests for links to either articles or Clint, the loan program that you had spoken about. I think we'll get those afterwards and post those and make those available for folks.
Sure.
And the last question, it's a comment and a question, and we have 2 minutes left. I'm not sure, but really someone agreeing that utilizing primary care and preventative care are essential to reduce costs. But they mentioned that they believe there's a lot of distrust in healthcare in the United States. Their question is, how would you propose addressing distrust to increase preventative care and primary care utilization throughout rural communities?
Wow.
Yeah, we have a minute and a half, Clint.
Yeah. Okay. So my minute and a half is primary care. So primary care is relationship based. It's cognitive based. It's not procedural based. It's not widget based. It's relationship based. And until we start moving away from a transactional experience in healthcare to a relationship one, we will be hard pressed to get back that trust. And unfortunately, when we see the billions of dollars that are moving into, and it just gives me pains to say this, into the value-based care space, that trust is going to continue to be eroded. So the only way I think we're going to get that is through primary care relationships with individual patients where they know you've got their back, that you're not being paid to do more to them. You're being paid to do what they want and what's going to make them healthier. That's where I think we're going to get to that. We're not going to get to that in fee for service. We're not going to get to that in the billions of dollars that unfortunately I think are going to be making it more difficult for those relationships to develop in primary care. And I don't want to end on such a sour note, but nonetheless, whomever asked that question, it's just so vitally important, And I think it's relationships is going to make the difference.
Clint, thank you very much. I know we're up against time. Really want to thank all of our participants today. Just a reminder, this was the first in a series of 4. Our next webinar session will be on May 2nd, and Clint referenced it. That will be Janice Walters from Rural Health Redesign Center. We'll be talking about the Pennsylvania Rural Health Model, which focuses on global budgets. So again, hopefully, if you haven't registered, there's still time to do that, and appreciate everybody attending today and look forward to seeing everybody on May 2nd. Clint, thank you very much. Have a great day, everybody.
Thanks, Tom. Thanks, Josh. Appreciate it.
Thank you.
Okay. Bye-bye.
That was great.